Peripheral neuropathy is a condition that affects far too many people in the US, in Canada, worldwide. But my guest today is a leading researcher, physician, and teacher of other physicians, both in the world of peripheral neuropathy and also how diabetes impacts neuropathy or vice versa. My guest today is Dr. Stephen Barrett. This interview was, honestly, it was a gift to me, and I think it's going to be a gift to a lot of you guys as well. Dr. Barrett is a board-certified physician by the American Board of Foot and Ankle Surgery, as well as the American Board of Pediatric Medicine. He formerly served as the president of the Association of Extremity Nerve Surgeons. I mean, his bio is huge. I'm not going to read it to you here because I'll just bore you to tears. And really what you need to do is get to the meat of this episode and hear this man speak. Another opportunity to hear this man speak is to check out his TEDx presentation, which is named Some Nerve for Saving Diabetic Lives. So suffice to say that Dr. Stephen Barrett is an incredible resource, and I think has so much to share, both in his attitude, his professionalism, and his approach to complex problems. So to learn more from Dr. Barrett or about Dr. Barrett, you will want to go to nervetx.com. And I think he may even give his email at the end of the podcast. But if he does, you're lucky. If not, go to nervetx.com and you will be able to find him there, or check out his TED Talk. As always, if you get value from this episode, please make sure that you share it with your friends, your family, and anybody else who you know who will get value from it as well. Leave us a 5-star review if you're feeling the love. If not, by all means, move on. And I'm so excited about this episode. I'm just going to stop talking right now and let you dig into it right after we hear from our sponsor. So thank you so much for being here. Totally appreciate you guys, as always. And I look forward to hearing your comments on this interview. Enjoy.
Hey folks, just a quick reminder that all of the information presented in this podcast is for information purposes only. No medical advice, no diagnosing, no treatments suggested here. Before you try anything that you hear about or learn about here, make sure that you check with your medical provider. Dr.
Stephen Barrett, such a pleasure to have you here. I'm so excited for this conversation.
Well, likewise, I appreciate the time to spend with you today as well.
Oh, I think this is going to be so good. And you guys are in for such a treat. So we are going to start this episode as we do most episodes, because I think that you just have a great story. Everybody has a great story, but your story is exceptionally great, as we were talking about before. And so if you could share with the audience a little bit about your background and how you got to this place where not only are you're kind of, to me, you're bridging the world between conventional medicine and what we would call functional medicine, and in a very, very, in an area that's in high need of this stuff. So tell us about yourself, Dr. Barrett.
Well, let me preface everything that I think you really have to be open-minded, and you have to integrate everything available that's out there, whether it's considered functional or integrative medicine or traditional medicine. And when you treat difficult things like peripheral neuropathy, it humbles you very quickly, because there's many things that don't work. And most of the time you have to have some type of an amalgamation and bring everything you possibly can for that patient. And clearly when you get to that realization, then you start adopting these other things that weren't taught in the traditional medical school pathways. So my story is kind of interesting, because in the early 90s, I didn't really like the way one of the common foot conditions was being treated, called Morton's neuroma. And it's not a neuroma at all. In fact, it should be called Morton's entrapment. But we developed a way to decompress it rather than cut the nerve out. And that led me to crossing paths with my mentor, who's was a professor at Johns Hopkins and in plastic and neurosurgery. And he took me under his wing in the late 1990s, early 2000s. His name's Niddam. He just retired last month, I believe. And anyhow, Dellon had made this incredible observation that people with diabetic peripheral neuropathy, most of the time, or in a large majority of cases, let's say, their nerve symptoms are due to the fact that because of their metabolic condition, the nerve swells, and where it goes through a tight tunnel, like the carpal tunnel in the hand, it causes a focal nerve entrapment. So if you relieve that focal nerve entrapment, then all of a sudden, many of the symptoms of diabetic peripheral neuropathy can go away completely, or to a significant level where a patient now has a protective sensation. So when a diabetic patient loses protective sensation, that increases their risk of ulceration. A subset of them will go on, unfortunately, to have an amputation. And once you have an amputation, then your life expectancy is less than about 5 years from that time. So it's a pretty significant and very serious disease, not only from the mortality standpoint, but also the amount that some of these patients suffer.
Yeah, I have a question for you just to clarify. So when you say loss of protective sensation, you're talking about basically going numb, like the nerve stops. Is it that the nerve stops sending the pain signal? Because if you could clarify that, I'm just not clear on it.
I'd love to clarify that, but
Thank you.
There are some folks that have incredible amounts of numbness, but yet can feel everything very well, which is
Really?
oh yeah. So
That's really odd.
no, it is very odd. It is very odd. But basically, protective sensation is provided by the A beta fiber, which is one of the three main fibers in the peripheral nerve. There are more fibers, of course, but for our discussion, let's talk about the three that are really, the most concerning or at the top of the list. The first would be the motor fiber. That's what makes the muscles contract and work.
Yep.
The second is the A beta fiber, which is the sensory nerve fiber. And that tells your brain that your skin is being touched or pressed by something. And then you have the C fiber, which is a pain fiber. And then you have delta fibers, D fibers as well. But the A beta fiber is the first fiber to be affected by a focal nerve compression. Okay. So when that fiber loses its ability to function, then you become insensate. So your level of sensation, and it's such an insidious process in many people, they don't even know that they don't have sensation. And you can test them and they'll say, no, I can't feel that. So they may not have the feeling of numbness at all, but yet they can't feel. So
but they can feel pain.
They can feel pain. And
so then for sure they don't know they can't feel. Yeah.
Right. So nerves are really fickle. They're very individual. And the more you study and spend time with patients who suffer from neuropathy, the more humble you get, because some things just don't make sense from a peripheral nerve standpoint. But to go back to the insensitivity, so if you're unable to really feel something because of this compression, then you could, a pebble could be, in your shoe, and you could walk around all day and you take your shoe off and it's filled with blood and you've never felt anything painful at all.
Wow.
And then, if an infection sets in, then you have a problem. So in diabetic peripheral neuropathy, you have really two components that you have to worry about it. One is sensation, the neuropathic component, and the other is what's the vascularity. And there's almost always some component of microangiopathy with the peripheral neuropathy. But what's interesting is many times when we decompress these entrapped nerves, the circulation will improve. And the question is why? Well, there could be a couple of reasons. One is because the nerve now can function, and that provides some homeostatic benefit to the extremity. The second is that the nerve many times will run through a tight tunnel where also the artery runs through. So if you open that up, you've released or relieved a mechanical component of compression. That's a long story before telling my story, but basically I was just lucky enough to cross paths with Dr. Dellon back in the late 90s, early 2000. I ended up helping him train surgeons. We trained about 300 surgeons in nerve decompression and lower extremity nerve surgery, other techniques. And I think one of my emotions when I first met him and went up and started spending time in his office was that I was kind of unhappy because I'd seen all these patients for such a long period of time and we were told, sorry, there's nothing you can do. You just have to live with your condition. That's it. Go home, take some Lyrica, take some Neurontin, and that's the best we can do. That's it. And so that didn't sit real well with me because here I had all these patients flickering in the back of my mind that I said, there's nothing that we can really do except give you a drug to maybe mask some of the symptoms, but certainly didn't provide them with any benefit for improved sensation and protective sensation. So then, we started into, this rabbit hole, so to speak. And now 20 years later, all I do is peripheral nerve. And the more we did, the more we realized that there's still a lot of things we need to do to optimize the human, because although we all want that one magic hammer or one magic bullet, there is no such thing. And so that's what led me into the things that we'll talk about with peptides and some of the other, things that we do to try to make these patients better that have peripheral neuropathy.
Yeah. So that's, so the peripheral neuropathy, it's so interesting because again, peripheral neuropathy, I'm going to say is in my Facebook community, it's one of those issues, like people are just at their wits' end. They don't know where to go anymore. And it's clearly not just a question of taking some anti-inflammatory. They do sometimes experience some, and I guess we'll talk about this, and maybe if they're not too far gone, I mean, I don't know under what conditions this is even possible, but occasionally you'll come across someone who might get some benefit from a BPC 157. I haven't seen much great results with ARA 290, which is another peptide people have done some research around it in nerves, and mostly it's the chronic fatigue, I think, myopathy. But occasionally they'll get that benefit from the BPC 157. And I wonder if maybe that's someone who they haven't gone so far down that path yet, that just even that little bit of anti-inflammatory benefit and the BPC 157 has some benefit for nerves. So I'm just wondering if it's possible that when it's not too far gone, that BPC 157 might be enough just to help a little bit. I mean, not that it resolves the issue, obviously.
So I think the thing is that, when you talk about peripheral neuropathy, well, what does that mean? Because it's a very nebulous, broad term. Peripheral just means outside the central nervous system, outside the brain and the spine, of course. But neuropathy, if you break it down, it's Greek derivatives, neuro and opathy, just means something's wrong with the nerve. So it's not a very
broad.
Yeah, it's so broad that it's really not even helpful, to tell you the truth, because I mean, you can have a neuropathy from a contusion. You can have a neuropathy from metabolic disease, like we've been alluding to. And you can have neuropathies from toxic mold, increased heavy metal exposure. There's myriad neuropathies out there. And so to categorize them all as peripheral neuropathy is really it's
disingenuous.
Kind of it's a disservice, because it doesn't help us figure it out. And I think that's one of the things that, we look at neuropathy totally different than most practitioners. And that is, we want to get to the cause of it. So you'll see the term idiopathic neuropathy, and idiopathic means we're just idiots and can't figure it out, or we don't have enough energy and emotional interest to figure out what's really causing it. But most of the time, if let's say that 50% of the time it's idiopathic neuropathy, probably a good 80% of those 50%, we can figure it out. It's not easy many times because, we'll do mold testing on them. We'll look at, heavy metals. I mean, we do, complete metabolic assessments on these folks. And most of the time we're able to identify something. So I think the first thing is to really dial in and say, well, we need a good, accurate diagnosis. And the sad thing is that patients can have more than one thing
Oh, yeah.
at one time. So they may have a reactivated Epstein-Barr. They may have, a high level of mold or less than ideal metals, these types of things. And so you have to really kind of treat the whole scenario. That's why these cases are not easy to treat.
Yeah.
And in truth, there's a lot of people, and most neurologists really don't like to treat peripheral neuropathy because
Well, that's weird.
I have a lot of neurologist friends. It's like, well, we don't really like to treat that so much because, all we can do is diagnose it and, give them, gabapentin or Lyrica and, that's it. And so we've taken a different approach. We have to look at, well, why is this person having some problem with their nerve? And then, so to circle back to your question about BPC 157, I love BPC 157. I've seen unbelievable benefits from it from a musculoskeletal standpoint. I have not had much experience at all with it from a neurological standpoint, but this is one of the things that we were talking about earlier with the bioregulatory peptides, because I think that if you just make the person more healthy,
Yeah.
and you improve their circulation,
Yeah.
you're going to decrease their symptoms of neuropathy, even if it's an idiopathic case where you can't figure it out. So I don't know if that answered your question or not, but
Yeah.
I think there's certainly no harm giving somebody BPC 157. And it's one of the few that you can take orally, and it can get past because it came from the gastric juices. But, so it seems to make, a big difference. Now, one of the places we do use peptides almost routinely now is on some of our nerve decompressions, especially if we're having to do revision surgery. So I use thymosin beta-4 on every one of those patients to decrease the scar tissue formation after surgery. And if they've already had surgery, they're a mess from a scar tissue standpoint, and they're going to scar more. So we'll try to do everything we can to mitigate that post-operative scar tissue formation, and that has made dramatic benefits.
Interesting. So, okay. So before we jump into the peptides, I wanted to talk a little bit about what you used to, your progression, right? You
Right.
said that you used to use PRP, then you moved to stem cells, or I think it was stem cells, not autologous,
Right.
though, like
amniotic. Right.
Yeah. And then you found the peptide. So let's start with the PRP, because again, like I hear this a lot in the group. People they're to your point, they're scrambling. They're looking for answers. And, I heard PRP, I heard this, I heard that. And one of the things that you said that I think is so important, and so, it'll bring tears to some of these listeners' eyes, is that you mentioned the terms EBV or viral load or heavy metals. And of course, as soon as you have one of these imbalance, you become much more susceptible to the rest of them.
Right.
Right. So I think that even acknowledging that these issues are a part of this, of the catchment of what you're looking at is so incredible. But let's start with what you used to like. I mean, you came to a place where PRP was what you were treating.
Right. So until about the late 90s, when I was fortunate enough to cross paths with Dr. Dellon, I pretty much was a reconstructive foot and ankle surgeon. That was what I specialized in, and then, evolved into nerve from then. So I saw a lot of heel pain, developed a procedure called endoscopic plantar fasciotomy back in the early 90s. And that technique, we trained about 6,000 surgeons. So we saw an incredible amount of heel pain that, unfortunately, there's a lot of heel pain out there that has a neurogenic component to it, but it's in the literature about 93% of the time there's at least part of it's due to a disorder of the plantar fascia. And so I came across an article in the Journal of Hand Surgery, or one of the hand journals, probably early 2000s, I remember the authors there, Calandruccia and Edwards. I don't know why I remember that.
That is some memory.
But they just They just took blood from one arm and injected it into the tendon outside the elbow and the other arm, and the people got better. I thought, wow, this is really kind of interesting. So I started looking into it and thought, well, there's got to be something, to that. And the traditional treatment at that time for plantar fasciopathy was you just inject them with a steroid until that doesn't work, and then you do some type of surgery. Nobody took the time to really even look at it with ultrasound and know whether it was an elephant or it was a mouse from a severity standpoint. But
well, having been the plantar fasciitis route myself way long ago, when I used to teach high impact, they were called aerobic classes at the time on a concrete floor. I have a lot of sympathy for people with plantar fasciitis. It was a journey.
I do too. I've suffered it myself a couple of times, and I wouldn't wish it upon anyone. But back to your question about PRP. So after I saw that article, we did some investigation, and there were a couple of companies that were out already making platelet-rich plasma, and we integrated that into our practice, and it was really fantastic as far as how it regenerated it. So I hate the use of the term plantar fasciitis because in 2003, an article got published that one of the authors was Harvey Lamont, really brilliant guy. And they took specimens from 50 surgeries and put them under the microscope. And there weren't any histological markers of inflammation in any of them. So you had 50 specimens and you had 50 people that didn't have inflammation. And so that blew the whole paradigm right there that this is an inflammatory condition. And what did we do for it? We gave people NSAIDs and we injected them with steroids, which if you look at the literature, the steroid injections were really no better than just a regular lidocaine injection at 1 year. And the steroids cause a lot of problems because they cause fat pad atrophy. So they were not a very good thing. But empirically, if we could inject a patient with their own autologous platelets, right?
Yeah.
And then, it's going to induce some growth factors. And so we saw really within 6 to 8 weeks with ultrasound, not only did we have patients telling us, yes, they were better from a pain standpoint, but we saw changes in their plantar fascia that indicated that it was regenerated. Well, if you go back to the degenerative finding in 2003, that makes a lot of sense, right? Right. And I think it's great because it tells about how much the body can repair itself if you give it the opportunity. So then we did that for 6-7 years, and then amniotic quote stem cell injections came, and we used that, and then that was much better from the standpoint that people had less pain after the injection because it wasn't quite as inflammatory, and we just saw really better and faster results with that. And then about 2 years ago, I started using BPC 157, and that, I mean, we would see changes at sometimes 4 or 5 weeks post-injection with the amniotic cells. But with the BPC 157 at 3 weeks, we would see huge amounts of regeneration. Wow. So you can just see the tissue, how it repaired itself. So BPC 157 for musculoskeletal stuff is extremely good. It works really well in Achilles tendinopathy as well. So that was kind of where we got into it from really more of a musculoskeletal standpoint rather than a peripheral nerve situation. And then, we talked earlier this morning about hydrodissection and then the use of something like thymosin beta-4 after that in order to prevent the scar tissue from reforming. And so basically what you're trying to do there is, you're putting a large bolus of fluid. We use D5W. And that is does a couple of things. One, it kind of separates the tissue away from the nerve. So you get a little bit of a mechanical decompression. Some reason dextrose in 5% solution shuts down one of the voltage gated ion channels that conducts pain. Yeah. It's interesting because if you use dextrose in like 30%, it causes scar tissue formation, and that's used in prolotherapy.
Interesting.
Yeah, higher concentrations. So I guess all drugs come down to dosage, right?
At the end of the day.
Even exercise, right?
Yeah.
That's my favorite drug, exercise.
Yeah, I love that.
Yeah.
I love that.
But so anyhow, I think there's a lot of future for some of these peripheral neuropathy cases, particularly in cases where somebody's had an injury and something is entrapped or scarred down. There it makes a lot of sense. I don't see much applicability to like PRP if somebody just has some type of a systemic metabolic axonopathy where there's a disease process inside the nerve. So with peripheral neuropathy, you have to kind of, separate out some of these things because, well, if a nerve's swollen and it's pinched in a tight tunnel, like the carpal tunnel in the hand, well, we can decompress that and the nerve will regenerate, even in patients with diabetes, which is fantastic. There, I would not see much application for PRP. I would see application for thymosin beta-4 to, minimize scar tissue formation. But in a patient that has had, a bad contusion or a burn or something like that, that might be a really great application for, the peptides after a hydrodissection.
Yeah. And so when you're talking about using peptides like a BPC 157, whether it's for the I don't want to say fasciitis anymore, the fasciosis, right? for plantar fascia repair, or whatever else. And even you have a great story, actually. When I was first introduced to you, it was through a fellow physician, Gus, and of yours, and you helped his daughter with by using BPC 157 in a very specific way. So are you doing site injections?
Yes.
Like under imaging, like the whole, like I just kind of want to help the audience to understand, like, we're not just talking about a systemic into the belly injection here. Like, we're talking about conditions that are, they're very acute. And and there's a story for BPC for sure, systemically in many instances, but in terms of what you're talking about here, this is all very targeted and specific.
Right. And one of the important things is that, with the use of high, resolution ultrasound, we're able to see the diseased or the degenerative areas of the tendon. And so what we like to do is we locally anesthetize the area. So it's really a virtually painless procedure for the patient. But then under real-time sonography, we're able to put the BPC 157 or whatever we're putting in into that degenerative area. Now, one of the things that we do in addition to just infiltrating the BPC 157 is we needle that tissue a little bit. And so that's kind of like, if you think about it, it's like a debridement, so to speak. So you're taking this tissue that is diseased and you're kind of disrupting it a little bit by, multiple little fenestrations of it with the needle. And then when you put the peptide in, or the PRP or the amniotic, it just fills that whole area. You can see it on the ultrasound. It just fills it. So you're getting a really high concentration of that peptide in that area of where that tendon is damaged. And I think it makes sense to stack, oral or systemic peptides on, but you're not going to get that effect of the debridement, as well as the effect that, you're delivering a load that's really, really much higher than a systemic administration would allow.
Yeah. Well, it's kind of like sanding a piece of wood before you apply stain. You disrupt the surface area, right? And you give the ability for the tissue to absorb so that it's almost like it doesn't bounce off. I don't know.
No, that's a great,
in my
that's
mind. Like,
no, that's a great analogy, because that's what we do with diabetic wounds. So if we have a diabetic wound that's not healing, we can't put a biological dressing on it until we debride it, clean all of the dead tissue away so that there's new viable bleeding tissue below that will allow for integration of that biological dressing. So that's exactly what we're doing when we fenestrate or needle a tendon or a ligament.
nice. Yeah. Well, there's me just bringing it down to basics.
Yeah, I like that. I'm going to use that in my practice. We got to sand the wood before we stain. I love that.
There you go.
It helps
Imagine
patients a lot. It helps patients a lot when you can explain things like that.
Yeah, well, because they can kind of get their heads around it, right? It's almost
Right.
like, oh, okay, yeah, no, I get that. You
Yeah,
know,
that makes sense.
I can get my heads around that. So if so far, so BPC 157 is your star peptide for the time being. I suspect, knowing you, and I think well, and I don't know you that well, but from what little bit I do know of you, is that quality that we often lament that sometimes maybe gets sucked out of doctors as they go through the process of becoming a doctor, is this whole issue of curiosity, right? And
Right.
openness to something new. And have you looked at GHK-cu yet as an agent? Because again, it's another one that seems to be very helpful with scarring. The TB4, it's the antifibrotic effects, I think, that
Right.
we're seeing the benefits from.
I've looked at that a little bit, and I've come across really more with the hair follicle on that. Interestingly,
Interesting.
right?
Yeah.
Yeah, they're using it in alopecia and that. But to answer your question, no, but that's one that we should definitely look at.
Yeah, well, Dr. Lauren Pickart, who's the doctor, he's still alive. He's in his 80s now, and he's hard at work on a book on GHK-cu. So he's the one who discovered it back in the 70s. He might be an interest. I mean, I think of him as a grumpy guy because I've reached out to him a couple of times to do a podcast, and he just kind of grumps at me. I'm too busy. I don't have time for podcasts. I'm writing a book. And I'm like, yeah, but it's only an hour.
Right. And it'll get people to read your book.
Yeah, exactly. Right.
Yeah,
and no,
right.
in his mind, it's like, nope, book's got to be done first before I do anything else. But anyway, he's done a ton of research on it. So he might talk to you because you're a doc.
Well, I don't know, but
I don't know.
I'd like to talk to him.
Yeah.
I think that's the whole thing. Like you talk about, first of all, I love what I do. And one of the reasons I love what I do is because I learned that I really don't know that much, and I got to go try to learn some more. And then I realized there's more unknowns out there than I knew there were before I, became a little bit more educated. And peripheral neuropathy is the ideal thing to make you really have to either throw up your hands and say, I'm done with it, or I got to keep digging on this. We have to do some things here to figure out this for these patients, because they're really, you mentioned how severe it is earlier. I mean, I think about 10% of our practice is suicidal.
Really?
Yeah.
Well, because there's no escaping the pain, right? You can't, because I
it's
think painkillers don't even really touch it when it's really bad.
Yeah. Opioids don't seem to do that much. There's been a huge pushback on opioids, of course. And in all fairness, it's a pain that's 24/7 for people. Yeah. And they just get to a point where, if you have peripheral pain, then very quickly you have an alteration in your central nervous system neurotransmitters, and your ability to fight pain is greatly decreased. You rarely find a patient, a chronic peripheral nerve injury patient, that does not have some component of anxiety or depression. I mean, it's almost impossible. And now people manage that, in different ways, but it's a devastating condition to have.
Yeah. And do you find, because there was a book that I read many years ago now by a gentleman by the name of Norman Doidge, and it was called The Brain's Way of Healing, I think. Okay. I think that's the name of the book. And it was a series of short stories about different people who'd had different issues and how they dealt with it. And there was one guy who dealt with severe chronic pain. Mm-hmm. And he talked about addressing it actually from here.
Right.
Because what he was explaining is once you've had this pain long enough, it becomes like he was talking about almost you could resolve the source and still experience the pain neurologically, because it was almost like a vicious circle in the brain that you had to somehow break.
Right. And we call that central sensitization.
Okay.
And so you can have peripheral sensitization, where you have a peripheral nerve that's damaged to a point that it then starts to actually change epigenetically. It develops receptors that it's not supposed to have. It develops, the fibers that are not supposed to conduct pain. And so that's called central sensitization. But then in the brain, if you have a bad stimulus for a long enough period of time, you can get negative plastic changes in the brain itself, not only the cortex, but other parts of the brain. And so that would be called central sensitization. Now, a good example of this is like the wounded warriors. If they've lost a leg, they have, phantom pains, and they can feel their toes hurt, but they don't have any toes. And that's clearly imprinted on the cortex of that individual's brain. And that's what makes peripheral neuropathy so difficult, because many times it's not just peripheral, it's actually centralized as well. And so that's why you have to treat the whole patient. And, we send people routinely for psychiatric consultations, because there's nothing that I can do peripherally if the brain isn't ready for it. So they have to be dialed in by somebody who's really into that from a psychiatric standpoint, and they can get them, maximally better individually, so that, a surgical procedure may be then, very effective, and the outcome would be, much better. But if you just ignore that central component, you're doomed for failure. And so that's why you have to spend a lot of time with these patients, because the more they are able to tell their story, the more you're able to pick it up. I mean, we pick up a lot of PTSD, and there's an incredible level of PTSD in patients with chronic nerve pain.
It makes sense.
Yeah.
Right. Like you're traumatized just from, and anybody who's had a surgical procedure, let's say, or had a severe injury, you get exhausted from pain. Like constant pain it's just draining in a very unique way to the human system. Like it's because there's no getting away from it. You can't sleep it off. You can't. Right.
Well, and then the other thing is that your life as you know it is like taken away from you.
Yeah.
So you're not able to go to the gym. You're not able to, walk at the mall or do the things that, pick up your grandkids. It's almost like someone has stolen your life. And, that's very hard to deal with without developing some psychiatric overlay.
For sure. For sure. So you were talking about heavy metals and mold and EBV. Do you find, and you were saying that sometimes people have multiples of these, but do you find, like with the heavy metal, do you find a particular profile of patient that develops that? Is that the metals getting into the nerve somehow, or do you have any sense of how that contributes to the neuropathy?
So the actual physiological mechanism is pretty complex, but one patient that comes to mind is a lady that had a very unsuccessful hip replacement, and they used an implant with cobalt, and this for some reason just ground away, and her cobalt level was astronomical. And she came to us with her labs already and said, I have a high cobalt level. Nobody knows what to do to get this cobalt down. So I actually sent her to one of our naturopath colleagues who did chelation on her. And after about 6 to 8 weeks, brought her cobalt level down from like 33,000 to 3,000. Yeah. And magically, guess what happened? Her neuropathy went away. So, just having that excess load of heavy metals is going to play a role.
But wouldn't the implant just keep leaching?
They took it out.
Oh, they did.
Oh yeah, they took it out and then they replaced it with a non-cobalt implant, but they couldn't get the cobalt levels down. And
I
so
see.
so then
Yeah.
I
So
sent
that's,
her over to the naturopath, and they were able to chelate her very successfully and get this cobalt out. So, so you have to look at it. And I think what as you do with all patients, you kind of go through a systematic approach. You don't look for the rarest thing; you look for the most common thing. And we know that diabetic peripheral neuropathy is the most common, and so a lot of people don't realize that they are pre-diabetic or diabetic. I guess with the standard American diet or standard North American diet, that it's pretty hard. You're either pre-diabetic or diabetic. I mean, there's
yeah.
not unfortunately,
Yeah.
and so they'll be incredibly surprised when you look at their serum fasting insulin levels, and they have an insulin of 35 or 40, and you do a HOMA IR calculation on them, and it's 9.8 or something really high, and then that causes the hyperinsulinemia in and of itself, causes the nerves to swell. So we're able to take care of a nerve that's entrapped because it has become edematous or swollen. But we also want to take care of the person so that they don't continue to have these metabolic things. So you have to treat the whole human. That's what's missing in medicine so much right now, is people don't, and it takes time. It's a totally different type of practice. And if I see 16 patients in a day, that's like, I'm exhausted because they're complex and you have to really look at them. And it's not like a 70 patient a day internal medicine practice where everybody's like in and out in 2 minutes or something. It's
crazy.
Yeah, it's real difficult.
Yeah, no, it's really challenging. And you were saying earlier, and it's interesting to me, right? Because what you're really doing is you're going upstream. You're going,
Right.
This is this
Right.
whole root cause thing
Right.
that some people love, some people hate. But at the end of the day, it's like, yeah, I can treat your nerve pain, but if I don't know why it's coming, it's just coming back.
Right.
And you were talking earlier, I think it was before the podcast, about heel pain and how you will often diagnose person as being pre-diabetic or diabetic before they even know it, just because they have this heel pain that they've come to you because, they have intractable knee heel pain, like pain in their heel because of a nerve that's going, something about the calcaneus nerve.
Right. So no, yeah, you're right. So they'll come in and their chief complaint will be heel pain. And so again, you're going to think about the plantar fascia as the number one thing. And within 3 minutes after you've done a diagnostic ultrasound on them, you can tell they either have some component of plantar fasciopathy or they have a perfect plantar fascia. If they have a perfect plantar fascia, then obviously something else is going on. And there's a small nerve. There's actually several of these nerves on the inside of the heel called the medial calcaneal nerves, but they go through very tight little tunnels and there's not much tissue and there's an incredible amount of weight that goes through that part of the foot. And so if you have nerves that are swelling, they're going to show up symptomatically earlier in tunnels that have less, forgiveness, less ability for that nerve to expand. And one of those nerves happens to be the medial calcaneal nerve. So then you have to think, well, if they have this nerve entrapped, then we usually run another neurosensory test with a device that's called a PSSD, stands for pressure specified sensory device. It was actually invented by my mentor, Lee Dallin, up at Hopkins, and it picks up very early sensory abnormalities before these patients even know that they're manifesting sensory impairment. And then you look at all 4 nerves in both legs are affected. Well, now we know that it's not just heel pain on their right side. It is a metabolic condition that led to that. So now we're obliged to, well, what is it metabolically? We're going to get the blood test. So you see how it just takes you right down to like what you said. Let's get to the core of the problem. And we're trained as symptom treaters. And right? I mean, one disease, one pill, one deformity, maybe 10 different surgeries, but we're not treating the human. And
Yeah.
when you're able to find the cost, now unfortunately, a lot of times once the nerve is entrapped, even if we get the most compliant patient in the world and they do everything and they get all of their metabolics turned back into, pretty good shape, they may still have that nerve entrapment.
Sure.
But they're better. We have patients come in all the time saying, my vision seems sharper. I can think better. I can do all of these, we're not treating cognition. We're just treating them, stop eating all the sugar, super neuroinflammatory, start exercising, try to get your sleep, the pillars of good health. And it's amazing. It's amazing how the body will heal itself if you give it a chance.
For sure. But as you're saying, I mean, I guess if the nerve entrapment's gone on long enough, there's a certain amount of damage, and then you need the mechanical treatment that you would bring to bear through the surgery that would actually relieve that. And I guess that nerve entrapment in the heel is probably descriptive of other stuff that's going on in the rest of the body, but it's because the heel, like you can't not walk, you cannot exercise. You cannot do all these. So they wouldn't know that they might have the same thing going on in their shoulders, for example, because they're not lifting weights.
Right. Yeah. And so, diabetes, for example, as you know, affects all of the musculoskeletal tissues. I mean, it affects the nephron in the kidney. It affects the retina. Cognition. I mean, if you look at all of the stats with folks with type 2 diabetes, high levels of cardiovascular disease, dementia, neurocognitive disorders are, off the chart, cancer. So it's a disease that really affects every cell in the body. And what happens is that certain areas might be, the things that show up first. But I can guarantee you, if you have diabetic peripheral neuropathy, you have some impairment of your kidneys, you have some impairment of your vasculature. I mean, there's no way to just say, okay, it's only going to affect this part of the body or this cell type.
It's almost like it's the canary in the coal mine.
It is.
It's the loudest. It's the loudest, or the reddest, biggest flag kind of thing. But there's all kinds of stuff going on in the rest of the body at the same time. Yeah,
and it's really shocking for a patient to come in sometimes and their complaint is heel pain, and then they leave 2 or 3 visits later and it's like, well, you need to go to your internist or your family practice doc and get managed because you're diabetic. And they didn't know. They had no idea.
They had no idea. No kidding. Well, and and as you just said earlier, I mean, it's both sad and inspiring that by going back to the basics, you can improve so much. You may not solve something that's been progressing for a period of time completely, but that you can get that kind of improvement from something that's A, cheap, and B, pretty foundational.
Right.
I think that's really amazing. So one of the things, I find a lot of things really inspiring about you, but one of the many things that I find very inspiring about you is that you're actually training med students in this school of thought, which is, I just think it's so amazing. Like I remember when you told me that, I was like, there's hope. There's hope in the world.
So I've been involved with residency programs for 30 years. And about 6 years ago, developed a nerve fellowship program. It's 2-year fellowship. So they'll spend 2 years just studying peripheral nerve, and then they're pretty far down the rabbit hole. They can't come out.
There's no way out except forward.
No, it's just like, all right, you're in there, you're not coming out. But that's what we need to do. And then, the nerve fellows train more nerve fellows. And then we also have a very important organization called the Association for Extremity Nerve Surgeons, which we train. I don't know how many we train, but probably 30 surgeons a year in advanced and introductory fundamental peripheral nerve courses. We're starting to train more residency directors now so that they're, getting this into the residency curricula. We are making some inroads with the curricula at some of the schools where they're actually teaching it. But yeah, there's the old dogs like me. We're not going to be around for a long, long time. So we've got to get the new blood to start carrying the baton. And that's what we're trying to do.
Yeah, that's awesome. I love it. So looking ahead, so you've now, you've discovered BPC 157, TB4, and you're exploiting them to their max and continue to explore that. What are you most excited about looking ahead? I mean, I think everybody who's been listening to this podcast knows it ain't going to stop there.
No, it's not. No. Well, I think, the bioregulatory peptides, I think that's the next event horizon for me to go into that next black hole or rabbit hole, whatever you want to call it. Thanks to my colleague and personal physician who's absolutely brilliant. And you had him on, Dr. Gus Vickery.
Yeah, he's awesome.
I think maybe the only place I would question his intelligence is why he became a friend of mine. Other than that, he has pretty good judgment. But anyhow, I think that, this goes back to the core human. And he and I have had a lot of discussions about, treating the person rather than just the symptom. And I think that is the case with a lot of the peripheral neuropathies. And, that's why I look forward to seeing what we can do. And if you look at Caveson's research, it's pretty incredible when you see what he's done with the retinal scans and that type of thing. And those are very objective. It's not just somebody saying, yeah, my pain was a 10 out of 10 and now it's a 4 out of 10. It's like these scans are the scans. It's like the tendon on the ultrasound. It's either improved or it's not. It's a very objective finding. So I think there's a lot of, and it's not like these things haven't been around for a long, long period of time. It's just they've been undiscovered for a long, long period of time. And I think your podcasts with Bill Lawrence were great to explain that history and everything. But anyhow, I think that's the next horizon for us to be running toward, because I think we can make the person healthier, even though there's really not much written on peripheral nerve. But you would think that if you see some of the things from a central nervous standpoint, you would think, well, if it acts on the neuron inside the brain or the spine, why shouldn't there be a peripheral applicability as well? And I think that's our next thing. And I like, you always have to look at what's, the risk versus the reward. How dangerous is something for that patient, and in surgery, we're always balancing out, is the benefit outweigh the risk? And sometimes it doesn't. Sometimes we'll say, we'd be better off not operating on you. We've got to figure out some other way to go, because your chances of getting an outcome that we would want for you, let alone what you would want for you, are, not ideal. So I think that's where this will come into play. So I'm very anxious to do this. And because we work with students and pre-med students and have interns and fellows and whatnot, we'll be able to track this data and hopefully get some things published. But I expect, and I think one of the things too, if we do a study, one of the selection criteria would be, we have to have a patient who's willing to invest in it themselves, because a lot of patients will come to us and they don't want to do the work.
Yeah.
They just want you to write a prescription. Here's the pill. And then they're not happy a month later or 6 months later because they're no better. And the answer is, well, they've not invested in their own healthcare.
Yeah.
And so, I think that's the big thing. It's like, there is no magic pill. It's a lot of hard work. And I wish there was. I mean, it'd make my life a lot easier and make a lot of other people's lives a lot easier. But when you have a condition like this, you have to be invested in it, and you have to say, okay, I'm willing to do the work if somebody shows me how to do the work, and augment that with what we're doing with the peptides and all of the other things that we do.
Yeah. Well, those patients will often say it didn't work, and therein lies the nut, right? It won't work. Actually, the work comes from you.
Right.
Or if anything, it's a collaboration, right? You have to, it's working with it, working with, and I will often talk to people about finding a physician who will walk with them. Because
Right.
to your point, for someone of your stature to say we don't have all the answers and it doesn't always work, it means that you're on a discovery process with every one of these patients as you move through your continuum of what you're going to look at and what you're going to consider, and they're contributing to that hugely.
Well, and so I think there's a huge mind-body connection as well.
Mm-hmm.
And I think that unfortunately with peripheral neuropathy, people have lost hope. And
Yeah.
when you have lost hope, it's hard to press on and to buy into, all right, I'm gonna, chop the wood, tote the water type of thing, right?
Yeah.
And so there's no way, I wished I could figure this out, but there's
Mhm.
no way to ultimately motivate somebody to do something. I mean, education comes close. We can give them all of the reasons of why it's good and what it could do for them. But until they're willing to buy in and say, all right, I'm going to go through the pain of what I need to do. I'm going to give up that bag of potato chips. I'm going to give up these sugary things.
Yeah.
Until they're willing to do that, it's really, we're kind of handcuffed,
Mhm.
and there's nothing I like more than the motivated patient. I end up spending, you spend more time with the motivated patient because they want more. What, I'm doing all this and what more can I do? That really, because if you think about it, we do what we do because we want the patient to get better. That's it, and there's nothing worse than, going home at the end of the day going, oh man, I just can't get these, 3 or 5 people that I saw today. I can't move them. I can't, and part of it is the condition. Part of it is, are they willing, how motivated they are. And then, we still need to discover some more things. But I think if you come to the table with a condition like that, and you have a physician that kind of looks at all of the different things and you're willing to invest and buy in and do the work, I think there's great hope for many, many people.
Yeah.
And I'm much more positive than I am. I really don't have a lot of pessimism, other than I just wished I could get the motivation pill and just like give everybody, okay, here's your motivation pill. You take it.
Let's do it.
Yeah, let's get it done,
Well, although there's a lot of people will say, and maybe you found this as well, that there something about the BPC 157 is that sometimes, even before someone has fully bought in and invested, it gives them a glimmer of hope. Like it gives them a sign that things can get a little bit better. And just that, even though it can't do all the work, just
Right.
that little bit of improvement that they see kind of fuels this fire of, well, wait a minute, if I can get this far, well, what else can I do?
Yeah.
Like it can sometimes reignite that belief that things can change.
Yes. And I think that can happen with a lot of disease processes. If you just give the person some more energy,
Yeah.
right? And if they have more energy throughout the day, then they can go to bed and sleep better at night.
Mm-hmm.
Well, now all of a sudden they have an improvement it's an integral, but at least they have enough energy to say, okay, I see a little difference. And I think the BPC 157 is great for that.
Mm-hmm.
One of the things I discovered a while back is, and I'm, like you said before, I'm a hybrid. So I'm going to take whatever functional medicine and whatever, and I'm not a big pharma fan at all, but
okay.
big pharma has done some great things for us. I mean, if you look at some of the infections, people would die if we didn't have these antibiotics and everything. But at the same time, you can't just write prescriptions to cover up all of these problems. But if you ask the nerve patient, how do you sleep? I guarantee you 99 out of 100 will say, not very well.
No.
And then you follow up that question. Well, do you fall asleep throughout the day? Oh yeah, I have to take naps because I don't have any energy. So if they're taking naps and they're falling asleep at their desk, they're in this quagmire of they can't really get sleep, and and sleep is so important.
Mhm.
Without it, you die really.
Yeah,
And I
for
think
sure.
Matthew Walker's book, Why We Sleep, is a fantastic book. I think every person should be required to read that because it's so important. But anyhow, one of the things that we discovered is that if we would give a patient that was in that type of a situation some modafinil, then they would be able to stay awake throughout the day. And they didn't nod off all the time. And then guess what happened? We didn't have to really give them anything for sleep because they were
They're
able to go to
exhausted.
sleep. Right. And exactly. And then, the dopaminergic effect of that drug, I think, gives people a little bit of hope. And so of course, it's kind of an off-label usage, but we're still allowed, albeit with everything that has been said, to use drugs off-label. But that's an interesting way to look at it. And it goes back to what you're saying, is that if you give them a little bit more energy, and that's why I think the bioregulatory peptides may really do that, because you're not asking a big buy-in from the patient. It's not like, I got to have you down to the gym and doing all of this and doing all of that. All we got to do is, you just got to swallow these pills every day. And then we measure them. And the other thing is, patients love metrics, right? So if we can show a patient that their blood pressure has gone down, or their hemoglobin A1C has gone down, their lipid panel has gotten better. All of these things, most people are able to see numbers. And like intraoperatively, when we do a nerve repair, many times we'll do intraoperative EMGs. So we have a number of how much that nerve is conducting before it's decompressed, and then a number that, so it may go from 600 to 6,000 after the decompression. And the patients will look at that and they'll say, wow, okay, now I know that, and I take a lot of intraoperative photos and I give them because a lot of times they internalize, I must just be crazy, it's in my head. But when they see that picture of where the nerve is pinched and it looks like an hourglass, it's very easy for them to understand, yes, I did have a nerve entrapment. So now that gives a huge psychological benefit to them, because they know it wasn't just in their head. They weren't just making it up. They had a real condition, and just, you validated it.
Yeah.
And
no kidding. And they've won.
They won.
Like, for
right?
them, it's a win, right? Like, it's a win.
Exactly. Yeah.
Amazing.
And it's one of those things where you build success upon success. But the average patient that comes in to see us, they're with us for 18 months, 24 months, because it's a process. It's not like, okay, we'll see you next week and you're good.
Yeah. It's a different,
it's a totally different animal. Yeah.
No kidding.
But it's exciting, because I think the peptide thing is just, it's the next frontier that we really need to get to.
Yeah, no, I agree. And I think it's really exciting when people like you and Gus kind of get enthralled by them and start digging in and leaning in and playing with them, and exploring what you can accomplish. And I'm really excited to see what happens. And, I'm hoping that I don't know, whether it's 6 months or 12 months time, we can hop on another podcast and talk about what you found.
Oh, I'd love to do that. I'm starting with my N of 1 today.
Amazing. So. Amazing.
Well, back in the old days, the Chinese medicine, the Chinese doctor couldn't do anything that he hadn't done to himself.
Yeah.
So it's like, here, take this herb, But I love the N of 1. But to go back, one other thing is that when, like Dr. Vicker and I, we really get excited about this stuff. First, it's an academic excitement. You're reading this stuff in journals and you're looking at people who are lecturing about it and that type of thing. But then once you cross the abyss from clinical or from intellectual understanding into clinical implementation, and you actually see it work on a patient, that's like reading 1,000 journal articles. It's like, even though you knew it was going to do it, when that person comes in and says, wow, I can't tell you how that, it's like that then pushes you that much farther down that rabbit hole. And I think that's what we're going to see. And I'm really excited to try that.
Nice. Well, it's going to be a fun ride for sure. So, Stephen, I think we could keep talking for a really long time, but maybe what we'll do is we'll leave it at this, and with a promise of a continuation down the road.
Absolutely. Yeah.
But before we say goodbye, maybe you can tell people how they can reach you or your clinic if something they've heard here has inspired them to think, hey, maybe I could be the next one.
Yeah. So probably the best way to get a hold of us is at nervetx.com. And you can email through that, read about a lot of the things that we've talked about. We're trying to get a kind of an exciting little tool on our website where if a patient does have heel pain, they can answer some certain things, and the algorithm then tells them how likely they are to have a nerve entrapment versus just plain plantar fascia. So that could be a useful tool for people.
Yeah.
But that's really the best way to get a hold of us, or usneuropathycenters.com. But it's easier to say nervetx.com. So
TX, you're in Texas?
No, TX just for treatment.
Oh, treatment.
Okay. Like RX, TX,
Got it.
Yeah. So that's why we did that.
Okay. And where are you located? Just so people know, because this is not telemedicine medicine here. We're talking hands-on stuff. I mean,
Well, we do actually a lot of telemedicine with initial patients because about 30% of our patients are from out of state, but we're in Marietta, Georgia, which is just outside of Atlanta.
Okay, great. Amazing. Well, Dr. Barrett, it's been such a pleasure today talking with you again, and I'm really looking forward to talking with you again.
I am too, Natalie, and I appreciate your time, and I really love your podcast. So I just have to figure out how I can get more time in the week where I can listen to everybody's great podcasts because it's very good. But thank you.
Thank you.